Assalamu alaikum. The long clinical consultation day. First scenario, Mrs. Vicky Daniel, 29 years old, with a complaint of short breath and chest pain. Please take history and examine her, address her concerns.
Hello, I'm Dr. Muhammad. I am one of the doctors here today. Can I confirm Miss Vicky Daniel, 20-year-old?
Dr. Sally, unmute yourself, please.
Yes, I'm Vicky Daniel.
We are here today to discuss some health issue for you. I will take some history and do examination, and all our talk will be confidential. Okay?
Okay.
Can you tell me in your own word what brought you today to the clinic?
Yes, I have shortness of breath for a long time. First, I was tolerated with this complaint, but now I found it so difficult to continue my life with this complaint.
So, sorry for what happened to you. The main complaint is the short supers, right?
Yes.
Since when started, please?
First, I have before 2 years, I have sudden bug in my lung, and it was treated. And after that, I have start to complain from this shortness of breath. My GP said to me it is.
بيت الله يرحم والديك ده تنو بنت هنا ولا ده تنو من ولا
Felt it is bronchial asthma.
Please, Dr. Sally, best to be slow, more to the phone, but I can't hear.
Sorry.
Sound more higher.
Can you speak loudly, Dr. Sally, please?
Okay. First, it starts with a bug in my lung, and it was treated. And after that, but I must continue to complain from this shortness of breath. After that, the GP felt it is called asthma, and he gave me an inhaler for that management. But since that time, I'm still continue complaining from this shortness of breath.
Sorry for that, Miss Vicky. But before this happened, you were okay. Your chest, your lung were okay before this. Or
Yes,
any
before
problem
these
from
2 years,
childhood?
yeah. Yes, before these
Any
2 years, I was fine. I have no any problem in my life.
Any information about this organism, the name, or any diagnosis for it?
No. The doctor said to me it is not so severe bug in my lungs. Even it is in a small part in the base of my lung, not so that significant.
But what's new now for your shortness breath become more severe, increased?
Yes, after that I have noticed that my breathing not like before, my fitness not like before. I'm continue to complain. It becomes more and more. Now I found difficulty to do my job, difficulty to proceed my regular life.
Sorry for that, Ms. Vicky. We will share our professional health worker to help in this issue and social work. Okay.
Thank you, doctor.
You notice that shortness breath increasing at specific time of the at night, especially when you are sleeping, you are awake by searching for air.
No, it is all the time, but it is more with my activity. When I took rest, I feel it better, becomes more better.
How much pillows you are at night you are putting?
No, I didn't use more pillow, just one pillow.
Any swelling in your limb, in your leg?
Yes. Now I feel my legs are heavy, till near below my knees, both of my knees.
When you put your finger on it, you put the press on it.
Yes.
You told me the rest without effort, your breathing become okay, right?
Yes. It is still, but I feel better. It's still shortness
Any
of breath,
cough?
but I feel better.
Any cough?
No cough.
Any phlegm?
No.
Coughing blood?
No.
Okay. Any increase in body temperature nowadays?
No.
Ever last 2 months?
No.
Any sweating?
No.
Okay. During taking your breath, you feel any chest pain?
Yes, I have chest pain.
Can you describe more about this chest pain, the nature of it, stabbing, heaviness?
It is dull chest pain. It is
If you
not
give
related
score,
with my breathing. It is I feel that pain all time.
when taking your breath, right?
No.
Okay.
No.
No relation to your breath?
No.
Okay. If you give a score for this pain from 0 to 10, how much severe it is?
It's about 4 to 5.
I will offer for you some pain reliever, okay?
Thank you.
This pain going anywhere to your arm, to your jaw?
No, just in my center of my chest.
Any sweating with it?
No.
Any awareness of your heartbeat?
No.
Uh, any change in your weight?
No. It's fine.
Any lump or bump in your body?
No.
Okay. Any joint pain?
No.
Any back pain?
No.
Any rashes or skin changes?
No.
Any muscle pain anywhere in your body?
No.
Any other preferences?
No.
Any swelling in front of your neck?
No.
Okay. Any past medical history? If not, I should know. Don't tell diabetes, hypertension, any.
No, apart from that asthma, I was fine.
You told me this asthma since you have the bug, not before, right?
Sorry?
You told me about this asthma that appeared 2 years back after the bug, not before. I
Yes,
asked it,
yes. Exactly.
any allergies before contacted with
No.
any other past medical history? If not,
No. Apart from
you
this,
have no medication, you take anything to relieve this?
yeah, I'm using that inhaler to inhaler for my asthma.
And it was some relief for you?
Exactly. No, because I'm still suffering from this complaint.
Okay, you know
But
the name of
I
this inhaler?
found some relief after using, but not totally improve my complaint.
You know the name of the inhaler?
Yes, it's called Betsonite and Bricanil. I use Bricanil on demand when I feel more shortness of breath.
Okay, Mr. Zia. Any family history? If not, cancer, anything?
Yes, my mom has also asthma.
I guess any allergies? No allergies?
No.
Any travel history soon?
Sorry, family has a what?
Travel history.
No.
Okay. Any sorry for the question. Any party drugs you are taking?
No.
Any blood transfusion?
No.
Okay. What's your job, Miss Lydia? Vicky?
I'm a domestic cleaner at a local law court.
How does this affect your job?
Yeah, and now I have started to stop working
Very good.
because my job is very heavy, so I found difficulty to continue.
Is that when you are at your work end better than when you are at the work?
No, when I took rest, I feel some improvement. But when I do my movement activity, daily activity, I feel more short of breath.
Sorry for that. Sorry for that, Miss Vicky. Okay, Miss Vicky. Uh, any tummy pain?
no tummy pain.
Any change in your water work?
No,
Any change in your bowel work, loose motion, anything?
no, it's fine.
Yeah. Do you smoke?
No,
Any alcohol?
I drink some at the weekend.
What about your period? It's okay.
Yeah, it is fine, regular.
Any pregnancy problem before? Miscarriage, anything? You have
No,
children?
no, I have no partner. I'm not married.
Okay. Yes. Can I examine you, please?
Yes.
I need to check firstly the appearance of the patient. Looks how much weight, body mass index.
It's not given. Sorry. Maybe about BMI about
Low
20.
or low or average or high?
Okay.
The
Sorry.
weight.
The weight of
The
the
patient
patient,
general appearance is how much weight? Low, average, high?
it is average weight.
Okay. I need to see his hand. Any clubbing, any thin staining, any. I will extend her hand for any flaps.
No. No clubbing, no clubs.
Pulmonary
But
erythema.
she looks ill and dizzy.
Okay. I need to see now her saturation and vitals.
Her saturation is 93. There is some cyanosis in her.
Cyanosis what?
There is some cyanosis in her
Then
in her fingers.
her lip or the
Yes,
finger.
in her lip and fingers.
Okay. I need to offer also now urgent EPG for her. And how much vital?
It is fine. Blood pressure about 120/80, pulse about 80,
Respiratory rate.
about 25.
25. Okay. I offer also oxygen for her until we finish examination. Any proximal myopathy?
No,
Any pallor, any jaundice?
no.
I will open mouth and check by torch central cyanosis.
Yes,
Okay. I will see lymph node, anterior cervical and posterior cervical and supraclavicular.
no,
In the face, any dropping of eyelid or facial asymmetry.
no,
In hand also, I should notice any muscle atrophy, especially in the lateral part of the hand, in the medial part of the hand. Muscle is okay.
no, it's fine.
Okay. I will do full chest examination. From away, I will tell her to take full breath and see any asymmetry and expansion. How is it?
Yes, she is look Disney symmetrical breathing.
Expansion?
Sorry,
Expansion.
expansion is fine, equal.
Okay. I will check B2 and the apex of the heart. It is on the felt in the left side. If I didn't hear, I will check by my stethoscope. It is in the left or on the right.
It is in the left apex.
B2,
B2 is loud,
GVB.
raised.
I will do percussion note how it is from the back.
2 minutes left.
Is is fine.
Okay, I will hear her by stethoscope. Any fine crackles or coarse crackles?
No,
Any wheezes?
no,
Okay, I will go to the liver. How it is? Enlarged, pulsatile, tender,
it's fine. No organomegaly.
lower limb edema.
Yes, till below the knee.
Okay, Miss Vicky, how can I address your concern, please? What's your concern?
Yes, I know. I want to know what I have.
Talking with you and examine you, Ms. Vicky, I have a possibility of a condition called allergic bronchial aspergillosis. asthma, aspergillosis asthma. This condition is related to the bug that you have before and related to your work in the domestic areas. It causes prolonged shortness of breath, and we need to do some imaging and some lab to confirm our diagnosis and to start our treatment. Okay, Jake? Vicky?
So I will be treated, I will return to my normal life.
We will share our lung doctor to start our treatment. It is different from person to person, but at least we can reach to near normal life after starting our treatment.
Okay.
Okay, Ms. Vicky, another
So,
concern?
it's okay, thank you.
Okay, Ms. Vicky, for now, we'll give you sick leave we'll admit you and to start our and put oxygen and start our investigation and lab and imaging and start treatment. Okay, Ms. Vicky?
Thank you, it's okay.
Okay, examiner question, time is up.
So what is your summary for this scenario?
We have Ms. Vicky, 20-year-olds, positive history of 2 years back of some bug infection in her lung on background of asthma plus or minus asthma, and it has after treatment become progressive. She has progressive shortness of breath. Affecting her quality of life by examination. There is central diagnosis and some criteria of right side heart failure or pulmonal. We have the low P2, high GVB, or lymphedema. In view of all of this and in view of her professional that she is working in domestic area, we put our diagnosis of allergic aspergillosis asthma.
Okay, so what do you have any other differential?
The uncontrolled asthma and the ABBA, we have also a complication of pneumothorax, maybe there. We need to by hearing chest, no difference of air entry, but we need to confirm this as a complication of ABBA and uncontrolled asthma, and also chest infection.
Okay, so how will you investigate for this patient?
Firstly, we'll admit the patient because she's in respiratory distress now, and we'll start ABCD approach, put her on oxygen and titrate up according to the need, and send urgent EPG to see the type, if it is type 1 or type 2 respiratory failure, and I will start to send after that, apart from basic lab, CBC for infection is RCBC, liver function, for congestion for the right side heart failure. I will send for ABBA, we'll send galactoman test and aspergillosis antigen, PCR يعني for it, and antigen, and chest X-ray imaging, confirm the diagnosis, and CT chest, and they may need, after sharing pulmonology, may need BAL for taking sputum culture and sputum antigen for aspergillosis. Also chest X-ray and CT chest, it will rule out the complication of pneumothorax.
Okay.
This is the investigation for the diagnosis. For the complication, we'll do and echo to confirm right side failure, and share also our cardiology team.
Okay.
Okay. As a treatment, start the treatment if as a multidisciplinary approach to specialized nurse and social occupational health, and education counseling with the patient to avoid the to take sick leave to be away from the toxic area. We'll start if confirmed DPA, it will be by steroid and antifungal. Antifungal, I think of ricanazole or caspofungin, I think. If pneumothorax, we'll deal by surgical team if need to the site of the pneumothorax, if it is need needle or mostly ICD. For right side heart failure, according to the cardiology also, we need diuretic and anti-failure measure.
Okay.
Are you done, Doctor?
Yes.
Dr. Sally? Any other
Yes.
questions?
No.
Okay, what other differential you put, Dr. Muhammad?
I told ABBA and uncontrolled asthma and the complication of ABBA of pneumothorax, or occupational asthma, and the complication of the right side failure for pulmonary.
Okay. Any other question, Dr. Sally, you want to add?
Yeah, it's fine now.
Okay, let's start the comment.
Regard the history taking, it was fine. It was covered for all respiratory system and cardiovascular system. Even the general symptoms, it included with other systemic review. He didn't ask about BIT and BERT. I'm not sure if he asked or not. Regarding the examination, he didn't look for the, he suspect right heart failure, so he didn't ask about the right ventricular heave. There was right ventricular heave. Apart from that, his clinical examination, it was fine. Regarding the differential diagnosis, firstly, this patient is put as primary pulmonary hypertension for first high possibility diagnosis. There is other possibility of secondary pulmonary hypertension due to recurrent emboli, but there is no history of emboli or no history of traveling or any associated related factor. One of the other differential chronic lung disease, they put at bronchiectasis, but no cough related to that complaint. The other differential they put at congenital heart disease. Other differential they put as they put her at collagen vascular disease related to SLE or scleroderma, but there is no skin rash, no symptoms related to skin related finding or dysphagia related to scleroderma. She has no partner, no traveling, so HIV is away from the history of the patient. There is also possibility of differential for drug-induced if she use any weight reduction medication, it can lead to this shortness of breath or other minimum possibility of differential is veno-occlusive disease. So for investigation of primary pulmonary hypertension, we will start with chest X-ray, ECG. Chest X-ray, it will show for us enlarged central pulmonary artery with clear lung. ECG, it will show right axis deviation and right ventricular hypertrophy. Echo, it will show right ventricular hypertrophy and decreased left ventricular cavity size. Fourth investigation, you will do a lung function test with impaired diffusion. Fifth, we will do ventilation perfusion scan. And the final and the spot diagnostic investigation is cardiac catheterization. So the definitive investigation for primary pulmonary hypertension is right heart catheterization. The management, it depends on vasodilator, heart-lung transplantation, and anticoagulant. Hello?
Yes, finished?
Yes,
Okay, so we are talking about pulmonary hypertension as idiopathic type.
yes.
So,
Idiopathic.
yeah, what do you think about the differential will be in this scenario? If we guess this is idiopathic pulmonary hypertension,
Yes.
what the
Next question.
differential? No, the differential diagnosis.
The idiopathic, no direct cause for this primary.
No. What other differential? You mentioned idiopathic pulmonary hypertension. So you mean heart failure could be another differential?
Yeah, congenital heart disease.
Congenital heart disease. Okay, what else? Heart failure?
No, they didn't put,
Ischemic.
they didn't put heart failure. They put collagen vascular disease
Okay.
as a cause of idiopathic pulmonary hypertension.
Mm-hmm.
They put veno-occlusive disease as
You
a
mean, yeah, chronic pulmonary embolism
yes.
or thromboembolic condition. Okay. Thank you, Dr. Any other comments you want to add?
No, it was
Okay,
clear an examination.
Mm.
Just apart from the diagnosis, differential, and the plan of management, it was different from the original diagnosis.
Yes. Okay, so let's review and revise with Dr. Muhammad
Yes.
why this patient is missed from him. I mean, he diagnosed her or he misdiagnosed her as allergic bronchopulmonary aspergillosis. What do you think, Dr. Muhammad? Maybe the questions and the answers supposed to have cough, right? With ABBA, allergic pulmonary aspergillosis, there is cough as bronchiectasis patient, right? Dr. Muhammad, you can hear me?
Yes.
Okay.
No,
And
يعني
she denied the
my
cough.
first thing in يعني no clues in the case. He told me only there is domestic. She's working in domestic and she will go to the allergic or ABBA. Second thing, pulmonary hypertension, it will not come at 2 years. It will come from young. It will start after, I think, 10 years early more than it will not be like 2 years only. That's why I didn't open my mind about primary pulmonary hypertension.
Okay, let's talk about the symptoms itself. Patient will present with exertional dyspnea, right? This is the main presentation.
Yes.
So I think maybe this is the only question you didn't ask. That what do you think the short of breath works with, or did you ask? I'm not sure
I
really.
asked it.
You asked. Okay, so this I think this the clue for the patient. Usually they are female, coming in the young patient, the young age, as you said, and the main presentation will be symptoms short of breath worse with exercise. Patient will feel short of breath while doing exercise. Sometimes this they might have chest pain. This is the main clue. With the time, pulmonary pressure increase, the patient even will have the short of breath and dyspnea, even with the sitting and even with the lying. So they will have orthopnea as well. Maybe this
Yes,
is
Dr. Bassem,
the main question.
what is the relation to have bug infection and to have the domestic area working?
Yeah,
يعني it should be يعني primary pulmonary hypertension يعني to catch it, it is not easy to catch it without some clues,
exactly.
or at least don't distract the candidate. You will distract me by another thing. I will go to the some rare conditions. It is not so common. يعني how many cases you have seen primary pulmonary hypertension in your life?
No, it comes in basis. Forget
Yes,
about
I know.
yeah. It's the incidence is high. Okay, in basis it comes. The problem maybe the questions or the answers from Dr. Sally. You ask about the short of breath with exercise. I think she mentioned maybe I am not sure about the answer, but this is the main complaint and the main presentation. Patient will present with short of breath, while he's having or while she's doing some activity. Started initially with minimal activity. Later on, it works with even the daily activity. Okay. There is the heart failure, right side heart failure. Yes, there is. So you will have leg swelling. Maybe also you have raised GVP, pulsatile liver, and congested one. Yes, you have to have these things. Plus cyanosis with the time, the patient will be in failure, of course. So he will have or she will have central cyanosis. Okay. I don't know. Maybe there is the answer itself was distracting, as Dr. Muhammad said. Particularly the asthma. Asthma always start as a clue if it comes initially as background or past history of asthma, which is not well treated and patient worse even after the diagnosis or not improving, you can suspect the allergic bronchopulmonary aspergillosis, and it came in cases. So you have to be ready with this case. You might present, you might have it. How you differentiate? The patient will have cough. Okay, so the ABBA patient will have a productive cough, like bronchitis, and it might be brownish. The phlegm or the sputum will be brownish, and the diagnosis, as Dr. Muhammad mentioned, you can do scope. You will have xenophilia. Okay.
Yes.
Back to the pulmonary hypertension as the causes or the the stage or the causes, the classification, Doctor. Or let me ask Dr. Muhammad, what are the classification of pulmonary hypertension, Dr. Muhammad?
Yes, there is four classification. This primary and cardio and thromboembolic CTF and
Always after the cardio, remember the respiratory in order because they are in order. Type 1, 2, 3, 4, and 5.
yes,
So type 1 is the
type
primary
1.
or the idiopathic, as you mentioned. Okay, it comes in female young age. That type 2,
Cardio,
yes, the heart, always the heart before the lung, right? The heart is the most important organ in the body, so the heart will come as type 2. Type 3,
uh, respiratory,
respiratory causes, exactly. So any respiratory causes like COPD, like asthma, like bronchitis, all of them can cause pulmonary hypertension. Type 4, as you said, chronic thromboembolic embolism. And type 5, miscellaneous, like HIV and other connective tissue disease. Okay?
Yes.
It's common, as I said, it came before the idiopathic one. Female in young age with unexplained short of breath. Started with a minimal exercise, later on towards even with the daily activity. Okay. Any question, Dr. Muhammad?
No, no.
So I think the questions maybe was distracting. The answer, sorry. That's why you might be missing the case. It's okay. At least you put it in your differential even in young female with the short of breath.
I
Okay.
think they put the scenario. I found this in. Maybe they put the scenario of that respiratory tract infection as a
Extractor.
yes, because they concern about the patient. She believes that he has a bronchial asthma, and even that she said they wrote GP felt it was bronchial asthma. They didn't even clarify that it was investigated and like that. So maybe this the weak point and misleading point for this scenario.
Okay. Okay. Any other question, Doctor? Anyone has a question or comment? I will send you your scenario, Dr. Sally. Your patient, Julia Smith, 38 years old, female with complaint of rash. Take history, examine, and discuss the concern. Anyone has any comment or question regarding pulmonary hypertension? As Dr. Sari mentioned, to diagnose pulmonary hypertension, you start with the basic investigation first, and the diagnostic tool here will be the echo and ECG. And the most accurate test to do, the invasive one, it's right side catheterization. Okay. I wrote your scenario in the chat box.
Yes, I saw.
بس
Okay.
هقول شغلة
Okay.
سريعة على موضوع الأزمة والpulmonary hypertension.
Yes, in English, please, Dr. Hinda, as usual. Sorry.
Okay. There is usually whenever you find asthma, unfortunately, a lot of conditions will come with a distractor as asthma. And it might be something not related to asthma at
Yes.
all. For example, you might have a COPD patient and he came from outside the card, is with asthma. Pulmonary hypertension from out with asthma. Cystic fibrosis patient and from out it is like asthma. So sometimes it is not even a case of difficulty controlled asthma. So the entry to the case should be to confirm how asthma was diagnosed. Just if you ask such a patient, since when you were diagnosed with asthma, you will find it was recently, he was recently tagged with this diagnosis when his symptoms started. Okay, so it is not like an adult onset or childhood onset or known case of asthma, and now it become difficult to control. Okay, so from the timing of diagnosis and how it was diagnosed, you will understood whether the asthma is a distractor and you have to look for something else, or it is a case of difficulty controlled asthma. And it is very common to see asthma as a distractor. At least for now, I remember pulmonary hypertension and I remember COPD, which is not related. There is something else you have to look for, the COPD risk factor, and you will go with something like different pathway. And cystic fibrosis also, sometimes it is misdiagnosed as asthma. And then later on, you discover that it has nothing to do with asthma, and it is not even a difficult to control asthma. So this is the first thing. Take care of those questions, which we usually ask to confirm about the past history of asthma, how it was diagnosed, blown test, or he was given inhaler as empirical treatment, and since when he was given this diagnosis. Always also like triggers, remember always in chest pain, cough and shortness of breath, always ask about exertion, postural, okay, movement, a specific movement to exclude musculoskeletal.
Yeah, the timing as well.
Ask the triggers very early, because at least if you find out that it is a shortness of breath on exertion, you will never misdiagnose the case as a difficult to control asthma, because difficult to control asthma usually it's rarely to come with shortness of breath on exertion, which is progressive. Usually asthma, whatsoever it will come with, it will be intermittent. Shortness of breath, intermittent. Cough, intermittent. Wheeze, intermittent. So this is another way to differentiate between a case of difficult to control asthma or like something related to asthma, which is usually intermittent. Even though difficult to control asthma, the condition which is causing difficulty to control can be a progressive condition. For example, as Dr. Muhammad said, allergic bronchopulmonary, it will be somewhat progressive. Carcinoid. No, carcinoid is also intermittent. Anyway, so try to establish whether it is intermittent or progressive and what is the original history of asthma. Because it's really common to have a distractor. Whatever happened with you now in the case, this is a real situation in the exam. You will have a job which is a distractor. She might tell you he's working in a factory.
Yes.
And it has nothing to do with the history. Pulmonary hypertension is not related to being a factory. To take you toward mesothelioma and asbestosis and asthma, occupational asthma, and you will stuck there. So having a distractor in the job is very common. They can tell you he have a domestic work or farmer or working in a factory. So all this, and you will ask yourself, what is the job of those distractor? It is not more than that you will use it in the differential only. that it might exacerbate, make things worse. And you will also point out those things in your management plan, that I have to advise the patient to be away from any irritant, away from anything worse, the shortness of breath. Okay, so just you will use them as a triggers or differential diagnosis down in your list, and you will use them as a non-pharmacological advices in your non-pharmacological treatment plan.
Yes, I have a question for you, Dr. Hind. If we guess this case is allergic bronchopulmonary aspergillosis, do you think the case will be established? Since the diagnosis will be established, the patient will have cough and it will be productive, brownish, and as we know, or it would be after long time of diagnosis. I mean,
You,
after chronicity of the disease, or since diagnosis will be the patient will have the cough, the productive cough, and so on. You
you
got my
mean
point?
that the difficulty worsening asthma will start with this asthma, which was like under control, then suddenly will become under control, or immediately the patient will go into exacerbation? This is your question.
No, my question about ABBA itself. Once already diagnosed, the patient will present with the productive cough.
From the start, you mean?
Yes, yes,
It might not be like this because it's a hypersensitivity syndrome. So it
yeah.
will pass through the stages,
So
and
it
it
will
will
take
give
time.
you asthma-like symptoms in the beginning, dry cough,
Mhm,
which was slightly responding. Then
mhm.
with continuous exposure, it
Yeah,
will turn it will turn into a full-blown picture,
bronchiectasis. Yeah.
yes, of bronchiectasis. But in the beginning, the hypersensitivity stage from exposure to the mold and the aspergillus
Mm-hmm.
is a dominating picture. Then with time, it will
Yes.
become like a full-blown picture of bronchiectasis. But
Yeah.
you will find like some months, like let's say 1 year, 6
Yeah.
months before this, with dry cough, asthma-like chest tightness.
Yeah.
Even sometimes will tell you that it was getting better with the inhalers, and now it is not, because the hypersensitivity stage have to take place before
Mhm.
the bronchiectasis will
So,
start to appear.
so my question again here in this scenario, if we guess this patient is asthmatic since 2 years, suppose if I want to say this is allergic bronchopulmonary aspergillosis, the patient will have cough and it will be productive cough because 2 years is enough to have established diagnosis as ABBA, right?
It can be, بس يعني الcough will be the main symptom
Yeah,
along with shortness of breath.
yeah, to have the diagnosis, we have to have cough.
We have to have cough.
Okay.
حتى لو كان الcough, even if the cough was dry and now productive, but
Yeah.
the cough is there.
Yeah, yes. So this is my question because the cough was negative or the patient denied the cough in this scenario. So we cannot say this is ABBA. There is something else.
Actually, it will be less likely related to allergic bronchopulmonary.
Oh, okay.
يعني it will not, it might be a differential because of his job, and you will
Exactly.
mention it at the end. As we said, the
Yeah.
distractors always, if they are not related to the main stem, you will mention them as a differential. Low, like you can say, I would like to exclude any occupational related lung disease, APP,
Yeah.
like hypersensitivity pneumonitis, since he's
Exactly.
working in a domestic. And it might not be consistent completely with the clinical picture, but just you add it in your differential
In
because of
your
his job.
differential.
Because of his job. And it
Yeah.
will be acceptable that you are safe doctor, and because of he is carrying out a high risk job, you would like to exclude some occupational related diseases.
Mm-hmm. Okay. Clear now. Thank you, Dr. Hind. Thank you.
You're most welcome.
Okay. Any other comment before?
Hi,
Yes.
hello everyone.
Yes. Hello, Dr.
I have one question for Dr. Sally. You've mentioned the differential diagnosis for pulmonary hypertension itself, but I was just thinking of differential diagnosis of the presenting complaint. So I was just thinking of pulmonary hypertension, heart failure, interstitial lung disease. So it depends on the question of the exam. The differential diagnosis, is it for the presenting complaint or is it for your first differential diagnosis?
I
Because
think,
when you mentioned the differential diagnosis, I haven't put the causes of pulmonary hypertension. So I put the differential diagnosis of exertional dyspnea.
yeah, this is the main concept that what I mentioned already and I explained. The presentation will be related to the exertion, right? In this scenario, I think it wasn't clear from the surrogate that the patient has this short of breath worse with the exertion. Maybe this is the most confusing point. Plus the exposure, yes, there is possibility, but as Dr. Hen said, we can put it as a differential, not as a diagnosis, particularly if we don't have a cough. Let's see the comment here. It is differential. I think Dr. Ines or who? Dr. Tofi. Yeah, this I think Dr. Gotov, right? She wrote that first differential as pulmonary hypertension, Eisenmenger, extrinsic allergic alveolitis, allergic bronchopulmonary aspergillosis, carcinoid syndrome. Yeah, I will ask you, Dr. Gotov, why you mentioned the pulmonary hypertension initially. You put it as a first, which is correct. What do you think?
Because this patient is a young female, she has
Yeah,
exceptional shortness of breath with chest pain, and she has
perfect.
no cough, and she
Perfect.
doesn't have the variability of asthma.
Yeah, I think
She
this is
just added the allergic bronchopulmonary aspergillosis and carcinoid syndrome as differential of uncontrolled asthma or misdiagnosed asthma.
yeah, you're right.
No,
I think
I
this is
agree.
the clue.
Yeah, I agree with you. Pulmonary hypertension should be in the top of the differential diagnosis. But my concern is, should I mention the differential diagnosis of exertional dyspnea when I've been asked in the exam, or should I mention the differential diagnosis of causes of pulmonary hypertension?
Okay, this is the question. Okay,
Because
yes.
she mentioned the causes of pulmonary hypertension, but when she asked about the diagnosis, I just put in my mind that should be the differential diagnosis of exertional asthma, exertional dyspnea. So I put pulmonary hypertension, heart
Uh,
failure, interstitial lung disease, or other causes.
yeah, I believe you have to put differential of the types, particularly if you have asthma. Asthma, one of the causes can lead to pulmonary hypertension with the chronicity, right? Any lung disease can lead to pulmonary hypertension with the chronicity. So you can put it as a differential. However, it's you can say again is that just newly diagnosed as the asthma, but it's still one of the differential. Pulmonary hypertension, either
It's
idiopathic
difficult to
type.
put it. It is difficult to put it if it is a newly diagnosed asthma.
Yes, yeah,
الأزمة
this again is
بتاعته
that. Yeah.
فأنت الأفضل إنك if you are like in doubt what differential
Mhm.
you want to give, really ask the examiner. Like if I am an examiner and you are the candidate and I told you give me a differential diagnosis, it will be totally clever question from the candidate. Do you want me to give you the differential of pulmonary hypertension, my top differential? If he is okay with this, he will tell you, yes, please proceed. So you will give him the differential diagnosis of the causes of pulmonary hypertension, which fit the case based
Yes.
on a young female who have, for example, family history or whatsoever. My top differential is idiopathic pulmonary hypertension, but I have to exclude cardiac, lung, chronic thromboembolism, and other miscellaneous causes or connective tissue diseases. But if he
Yes.
told you, no, doctor, when you will ask initially and you tell him, do you want the differential diagnosis of pulmonary hypertension? He will tell you immediately, no, I need the differential diagnosis of shortness of breath on exertion. So خلاص, you will give top differential pulmonary hypertension, then you will move to مثلا uncontrolled heart failure, interstitial, حتى interstitial lung disease, it need cough. So mainly you will have to put a shortness of breath on exertion, cardiac related symptoms. يعني مثلا unstable angina, if the chest pain was atypical, because there are sometimes angina with atypical chest pain. So you cannot really, it will be very difficult to put a lung cause for shortness of breath,
Yeah.
and there is no cough.
As
Because
I
most
said,
of,
Dr. Hindi, you can say again is that it's newly diagnosed. So it's
against
at
that,
least
it is,
yeah,
or against the interstitial lung disease, against that, no cough. But at least you
exactly.
have to put 2-3 differential before, which fit the picture. So go with cardiac. Mostly cardiac cause of
Yeah.
shortness of breath on top of pulmonary hypertension in view of her young age and being a female with no cardiovascular risk factor. Then you can put something related to premature atherosclerosis. She's young and have no cardiovascular, but she can have any cause of premature atherosclerosis. Like, for example, if there was any family history, familial hyperlipidemia, unstable angina with atypical chest pain, anemia. Okay, she's a young lady, she can have menorrhagia. Okay, so anemia, shortness of breath, and exertion.
Can
Yes,
lead to exactly.
and can lead to a secondary congestive heart failure as a complication. But you cannot start with a differential which need cuff. At least 1, 2, maximum 2. Okay, if you couldn't find the third one, then you can go to, for example, interstitial lung disease based on shortness of breath on exertion, but there is no cough. Okay, and then
You know,
you
Dr.
can
Hind,
the
I
occupation
think,
related.
yeah, I think if the candidate didn't mention at the top of the differential pulmonary hypertension, the examiner will not ask about the types of pulmonary hypertension. So whenever you mention something different than the diagnosis of the case, he will ask you what
See, I
else.
will tell you, it depends on the examiner.
Yeah,
There are
exactly. Yeah,
examiner
you're right.
who can accept to
Yeah,
find their top differential as a second or third.
yeah,
And they will not give you a hard time. خلاص, you put it second, third, Allah
yeah.
يسلمك إيديك. He will continue asking his viva with
Exactly.
that second or third.
Yeah,
Even if he get irritated, he will ask you to rearrange. As soon as
yes.
he will ask to rearrange, you will pick it up and it will be first or second. But unfortunately, there are some people who are like stubborn, like minded people. So they will يعني شو بيقولوا في كلمة حلوة كان حدا يقولها بيسوقوا معك بالحرام.
Yes. Then he will minus all of the
خلاص
marks.
بقى بياخدوا
Yeah,
أول
yeah.
أول
No, no,
differential
I think,
وبيمشوا عليه
رامبلر
الفايفا question و you lose
رامبلر
everything.
yeah.
رامبلر
Yes.
What is that? Maybe you are talking in the meeting, sorry?
I think yes, someone is forget his mic open.
Okay.
So take care just to like to be guided by the examiner. In case you feel the examiner is not happy with the differential,
Yeah,
don't let
try
him
to,
move. Don't let him move until you satisfy
yeah,
him.
exactly.
So you will not lose the judgment.
And
لأنه if you give an investigation and management of the wrong diagnosis,
exactly,
you
yeah,
will fall in the trap of
yeah,
linked skills and you will lose the judgment.
exactly. Yes, he will minus a lot of skills. Linked skills means differential, clinical judgment, physical finding, clinical, even identify the finding, and of course the
Or
differential.
usually if you did a good finding, physical finding, but you
They
stuck
can,
in differential,
mm,
and the differential second step which can be affected if wrong differential judgment. لأنه you will have a full discussion about something not related.
exactly, which is the wrong diagnosis.
So
Yes.
try to satisfy your examiner, like his face become happy with your differential before you move on to the investigation or management.
Yes. Okay, thank you, Dr. Hind, and thank you, Dr. Ahad, for your
Thank
question.
you.
It's a really good question. So always try to satisfy the examiner, as Dr. Hind said. If you are feeling the examiner is not happy with your answer, put another differential, even away from the case. Not away, I mean, if you put it and you can think it's fitting, say it. It might be the case, and maybe the examiner will be satisfied. Otherwise, if you didn't mention the case or the diagnosis, he might go with you in the discussion, and at the end, he can give you bad mark because he's discussing something away from the case. Okay, good discussion. Thank you, as usual, Dr. Hind. Thank you. We can start the second case. Dr. Sally, ready?
Yes.
Okay. As usual, others, please, you can put your differential according to the scenario. Here you go.
Hello, I'm Dr. Abdelal. You are Mrs. Julia, who is 38 years old.
Yes, I am.
It comes to my knowledge that it is okay to discuss with you about your condition and to examine you.
Yes, go on, doctor.
So it comes to my knowledge that you have a rash. Can you tell me more about this?
Yes, doctor, this ugly rash, it is distracting my life. It is on my hand since 2 months now and increasing. So I come here to see what's going on.
Can you show me this rash?
Yes.
Yes, in the chat box. Okay.
Wait. Okay. So, Mrs. Julia, you said to me this rash for 2 months.
Yes,
Do you have?
started little small and increasing.
Sorry for your complaint, Mrs. Julia. So, this rash, do you have any other rash in your body apart from this, your hands?
No,
Is this in your back of your hands? Do you have any in any part of your arms?
what?
Sorry, you
So
can continue. Yes.
okay. So you say to me that there is no rash in any part of your body from apart from this the
In my
back of
hand,
your hand.
in my hand is like this.
It's
Same
okay.
other hand, but little different. يعني it's
What do you mean?
not that severe, mild than this.
Where?
Other hand the same, but this is on both hands.
It's okay. So this rash, is it appear before and disappear and return back?
No, no.
This first time before 2 months, you mean?
Since 2 months start.
Yes. So is this rash any itching in that rash?
Not too much. It is only uncomfortable only.
It's okay. Any collection of fluid, sac of fluid in some part of this rash?
No,
Any ooze or any bleeding from this rash?
no.
Um, do you can feel your sensation or you lost your sensation in your back of your hands?
No, no, my sensation is okay.
Okay. So any joint pain
Joint pain? No.
in it's okay. So if this rash exposed to the sun, it more become worse.
I become more uncomfortable when supposed to sun.
Sorry for your complaint. So do you have any back pain?
No,
Okay. Any other joint pain in your body?
no.
Um, any hair loss?
Hair loss? No.
Yes. Do you have any change in your body temperature? You feel that you are hot or
No,
any night sweat?
no,
Um, any lump or bump?
no,
Any increase in your water function? Any change in your water function?
no.
Any loin pain?
No in pain? No,
Loin pain?
no.
Any change in your weight?
My weight is average. Not. I didn't feel that I am losing or increasing.
Any change in your appetite?
Right? No,
Do you feel thick?
no,
Um, um, any throw up?
no.
So can I know if you have any medical issue before? Any medical problem?
Since a few months back, I have some issue in my abdomen, and I go to the hospital, and they told me there is some problem in my liver, and give me treatment. I don't remember it is a bug or it is what is the problem. I don't know, but I'm okay after that.
Uh, 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 they didn't. They told you about what was exactly the disease name
They
or
didn't give me the diagnosis, exact diagnosis, but they told me maybe bug, maybe something, but they give me some medication and I become okay after.
yeah. Sorry for your complaint. Did they ask you to follow them after that?
I didn't follow. Later on, I become okay. خلاص. Then when this rash coming, I thought it is some allergy, something simple. I bought some creams, I bought something, but no improvement. So that I came. But regarding my abdomen is okay. My tummy is very nice. Nothing. I'm doing nothing.
Any change in your skin color become yellowish in your eyes become yellowish?
At this time, yes. My friend told me your eye little yellow, but again, after taking the treatment time, I become okay.
Okay, sorry for your complaint. Any
I had
change
even
in,
some mild increase in my temperature at this time.
yeah, sorry for your complaint. So, any tummy pain?
No, no,
Any change in your bowel motion?
no,
Um, um, any change in the color of your bowel motion or in the frequency become hard or like that?
no,
Um, any change in your water function color?
no. My water work is okay.
Okay.
But
Can I ask if,
little increase. I feel it is my water work increase than before. You are right, doctor. But the color is okay.
yeah, so the increase in your water function.
Yes,
Any increase in the amount of that water function?
yes. I became little more frequent than before. I feel it is not the usual for me.
But the amount is the same like before?
No, also I think it is more. I think
Yeah, sorry. You said to me, I asked you that I think, do you have a loin pain?
no low in pain. Doctor, I asked it.
Any frothy of your water function?
No,
Um, um, so any chest pain?
no.
Any shortness of breath?
Shortness of breath. No, I'm okay.
Any cough?
No,
Okay. Any headache? Any change in your vision?
no,
Any weakness in your body?
no,
Any abnormal sensation in your body?
no.
Um, um, did you travel recently?
Travel? No.
Yes. So, Mrs. Julia, now you are 38 years. Can I know, sorry for this question, you have a regular cycle?
I noticed that nowadays also my cycle changed little bit, decreased, the amount decreased, the frequency decreased.
Sorry for your complaint. Do you use any medication this time?
Which time, doctora?
I mean, did you seek any medical advice regarding this
No, no. It is
change in
new.
your?
This is new for me. Also like that.
Sorry for your complaint. So, uh, do you have a partner?
No, yes.
Sorry.
Yes,
Um, do you use a pregnancy pills?
yes,
You are a regular for a long time.
yes.
So this rash, it occurs after using that pills or it?
For I think 18 years I am taking. I think no relation.
Okay. So okay. Um, uh, can I know? Do you have any other medical issue apart from that liver problem?
I don't remember, doctor. I am not taking any medication nowadays.
Okay.
Only
Any diabetes? Any hypertension?
no
Any bleeding from any side of your body?
bleeding. No,
Yeah. Um, okay. Any passage of blood from your back passage?
no.
Sorry for returning back for the question about that rash. If any trauma for this rash, any change associated after that trauma?
I didn't notice because no trauma happened. I am afraid to touch it.
Sorry.
I didn't. Doctor, I am afraid. I am very cautious to touch this rash to anything. So I am afraid.
Okay. So can I know if you have any medication apart from pills use?
No other medication, doctor. Only that time that give me some medication like 2 months back. Then nothing. I didn't take anything at that time.
Any old medication used before and you
Topical,
stop?
only some topical cream from pharmacy. Only
So who prescribe for you this topical cream?
my GB.
So he saw
Didn't make
this.
difference. Didn't make difference for this. No
Okay.
increase, no decrease, the same. Like I put water.
No previous use of medication and you stop.
No. Like what, doctora? Like what? Only
Any
some.
medication, any type of medication, herbal or any medical,
No.
you stop. Sorry for asking, any eliciting drug,
No.
any tattooing,
No.
any piercing, or
No.
any hospital admission or blood transfusion?
Yes, doctora. Since 3 years, I was have some fracture in my leg, and I think the operation was hard. I take 1 unit blood. I think I remember like something like this.
Sorry for your complaint. After that, did you after that blood transfusion any new complaint from after that operation?
No. I was okay. Only this last 2 months I become.
Okay, so I mean by my question, if you notice any tummy pain or any yellowish of your eye discoloration
No. I
at
was
that
okay at
time.
the time. No.
Okay, so can I know if you have any family history of similar complaint?
Family history. I think my mother has diabetes. Oh, my father also. Diabetes only in my family.
Okay, any running disease, any other chronic disease in your family?
Well, who I know nothing. I am away from them. I don't know too much about them really, to be sure.
Sorry for asking in detail. That blood transfusion is related from someone of your family, or it was from
I
other
don't
person?
remember, doctor, since a long time. This I can't remember more details.
It's okay. So can I examine you?
Yes.
So I will start with this skin rash to look for it. For you said to me no pain for that rash.
Yes.
Okay. I will check for the sensation to reassure about sensory.
Okay. Sensation.
So
Okay.
okay. So I will look for the vital sign of the patient, for the pulse, for the temperature chart.
Normal.
What about the temperature chart?
Normal.
I will check for any blood pressure supine and standing, sitting.
Okay.
Yes.
It's okay.
Any proximal myopathy.
No.
I will look for the eyes, for the pallor.
There is picture of the patient. Okay.
Yeah, 2 minutes left, but I will add one more minute for the concern, doctor.
Send the picture, Dr. Bassem.
Yeah, the chat box. I send it to the chat box.
No jaundice, doctora. No jaundice.
It's okay. So yes, I want to see for no jaundice. You say
Yes. No jaundice.
I will check for the mouth for any oral rash or any.
No.
Okay.
No
So
ulcer. No ulcer. No pigmentation.
I will look for any spider, any nevi, or any swelling in the face.
Swelling.
Any swelling
What's
in the face,
where is swelling? You need to ask.
below the ear.
No. It's okay.
Okay. So I will look for any raised JVP.
No. It's okay.
So I will look for any gynecomastia or
No.
spider nevi.
No.
Okay. So I will look to the abdomen and go to the abdomen for superficial inspection. Any pain?
Little on the right side of my abdomen.
Okay. So I will do superficial palpation. Is there any tenderness in the right side?
Mild.
Can I proceed to the palpation to look
Yes.
for the
Yes.
liver?
Go. Yes.
I want to see the liver span.
3 finger. Smooth. Little tender. Not too much.
Okay. What about a spleen? I will go to the spleen. Any
Okay.
spleen?
Spleen. Not palpable.
Any other organomegaly for the kidneys or other
No.
any lump?
No.
Okay. So I will look for legs for any swelling. I will do. Sorry, I will do for Any ascites, shifting dullness?
No.
I will hear to the back for any basal crackles of the chest.
No. Normal.
So can I know what is your concern?
Yes, doctor, what is this rash and it will be resolved or not?
Yes, most probably this rash related to that liver problem, and most probably this is related to that blood transfuse when you been operated for your operation. So I need to be reassured by doing some investigation to know is that what the cause for this related disease. Do you have any other concern?
Thank you, doctor. Thank you.
Okay, the timer was paused, so we can start quickly the examiner question. Dr. Muhammad, you can start.
Okay, doctor, tell me your positive finding and differential diagnosis.
Yes, 38 years female, complaining of rash in the dorsum of the hand, not itchy. There is tender liver. There is no clubbing in the hands. There is tender liver, about 3 centimeter below the costal margin. No other organomegaly. No other sign of chronic liver disease.
Is your differential?
There is a possibility for hepatitis C virus post blood transfusion with related disease skin rash.
Other?
Could be other type of bullous disease of a single infection. Could be any irritant cause, but apart from that, the history, there is no history of clear history about any irritating cause for the rash.
Okay, doctor. Your investigation and the treatment?
I will start with routine investigation, liver function test, renal function test, complete blood picture, blood count. I will do a bleeding profile, serology for hepatitis B, hepatitis C, HIV. I will do inflammatory marker. He has a mild fever, so I need to do ESR and C-reactive protein. He need abdominopelvic ultrasound. I need to do skin biopsy for more confirmation of the type of disease related. I will start with management. Is it related? If it is related to hepatitis C virus, I will start with the management of hepatitis C virus. And any symptomatic symptoms, any symptomatic treatment related to the skin rash, I will cover. If bullous disease, I will start with steroid management regard the bullous management. And if the other differential of irritant cause, to avoid irritant cause and any management.
What do you mean, doctor, irritant cause, please?
Chemicals or, but I didn't clarify more in the history about any.
Yes, you should ask her if it is related to any chemicals or not.
I didn't ask.
Yes. Must be asked. This is any rash in the hand.
Yes.
But she told you she bought some chemicals, but nothing. Sure, excluded.
Yes.
Okay, doctor. Any education counseling for the patient?
Yes. Regarding my patient education and counseling about the test for hepatitis C virus and HIV and hepatitis B and the plan of management and I forget to ask about the occupational related issue. So, and any if she in alcohol consumption or smoking should stop for both of them, and she need a multidisciplinary team from hepatologist, dermatologist, and infectious. Any and psychological support regarding his problem, and to treat according to the investigation result.
Okay, doctor, thank you.
Okay.
Still 25 seconds. I will ask here. Can you name the disease, Dr. Sally? The condition or the rash?
Yes, I forget. I think
You know,
porphyria
in cases. Yes, say it again. What?
porphyria related, but I forget the name of
Yeah, you are
porphyria
almost
cutanea
there.
tarda, or I
Yes,
think.
yes. You're
Yeah.
almost there. Yes, you're right. So please try to mention the name, not only thing. Even if you are not sure, say it. It might be it. Okay.
It's okay.
Okay. I think the time is up. Yes, Dr. Muhammad, you can comment now.
Yes, yes. She did great. Honestly, يعني we usually skin rash it is photosensitive or not photosensitive. طبعا it is clear it is in the hand, so it is photosensitive. So the most important, you started to exclude the lupus by any hair loss, any rashes, any scarring, any frothy urine, to exclude SLE. This is the most important. Second one, and it's common, if the rash in the face, it is SLE or dermatomyositis. I don't remember you asked about any problem
No, I didn't ask about this.
in the
But
outcome.
as I asked just in general about any other side of skin rash.
It should be clear for the examiner that you are asking specific question for this 3 or 4 diagnosis. That
Yes.
any problem in your muscle, any pain, any difficulty combing hair, any rash on the face, be clear. You exclude the lupus very nice يعني, from the beginning. And from the drug history, any medication, as you mentioned, if she take anything, any drug she is taking, it will affect, especially thiazide, can affect to do this rashes here. But now the specific here, that the rash, you have a rash in the photosensitive area, and patient stand in front, the second picture is stand hemochromatosis. So and we give history about you didn't ask about any surgery, but you told any past medical or any you ask it twice, so I give you the clue for the surgeries. So sure, he take blood, and he takes 3 years until become active. When with the recent he have hepatitis A also, so become active hepatitis A and hepatitis C. With hemochromatosis, porphyria cutanea tarda usually come with 3 association. Once tanned skin, خلاص hemochromatosis there. I told you I have increasing by my water work. يعني he's خلاص impending diabetes. It is new for him. You asked about other autoimmune, like I don't remember you asked me any whether preferences or not, but you mentioned any headache, anything. I don't remember also the anti-nutrition ship. I don't remember. But to conclude that the complication of hemochromatosis, including liver and pituitary and diabetes. He started has diabetes as a complication of hemochromatosis. Patient still compensated liver because it is new for him. So that's why no clear stigmata of chronic liver disease. But sometimes you can have 1 or 2 stigmata. You ask about 1 or 2. Better to ask generally all, يعني spider nevi, dubitrain, clubbing, leukonychia, all them to see in front, or till I am asking, I searching for the stigmata of chronic liver disease. So it is a case of, and the other also clue when I told you about the period become little, it is one of the sign of the pituitary malfunction, so or hypofunction. So it is porphyria cutanea tarda, with hepatitis C virus and hemochromatosis. About the investigation for the diagnosis, urinary and plasma profiling to confirm it is. طبعا the main complaint for the patient is rash. They don't care about other things. So to confirm the diagnosis, urinary plasma profiling, and for the complication or association, you will send, as you mentioned, for liver ban, including even HIV, even if no risk. And he has risk of HIV also by blood transfusion, and liver functional, including synthetic function, albumin and bilirubin, and as a complication for hemochromatosis, also alpha fetoprotein for it's common with hemochromatosis. For her period, you will send full pituitary also profile, especially FSH, LH, and prolactin, and يعني full pituitary hormone. Okay.
Yes.
This is for so we confirm the diagnosis, confirm the association. Also, طبعا as you mentioned, ultrasound abdomen important. Then treatment, education counseling. You should mention during taking the history. Are you taking alcohol? Are you exposed to sun? Please stop alcohol and just put some sunscreen until we manage and diagnose you. The treatment as for cutaneous tarda, porphyria tarda, phlebotomy, and anti-malarial hydroxychloroquine low dose. And طبعا for the complication, if for hepatitis C, we'll share our hepatology to start the double or triple therapy for him and according to PCR, and cosmetic therapy by the skin by dermatologist, and to confirm also porphyria tarda, as you mentioned, the biopsy, porphyrin and biopsy, and dermatology for cosmetic, because if you ask her about her job, I am accountant, and it is make me not comfortable in my work and affecting me, and my mood is not good after this. So, need some cosmetic with derma until treat the cause. You mentioned طبعا very important as you did for the decompensated liver, ascites. You asked about bleeding, vomited blood or blood stool or blood carrier stool, is conscious level at the decompensated liver. يعني 2-3 question for that, as encephalopathy, hematemesis, and malignant ascites.
Okay.
يعني generally you did good, but the main you didn't mention the diagnosis for the patient and the association or the complication of hepatitis C, HCC for the liver. I think this is the only miss there. Okay.
Okay, thank you, Dr. Mohammed. Yes, Dr. Sally, you can ask.
I think I say to him that is most probably related to that previous blood transfusion, or
If you mentioned it is related to the previous, but what is the diagnosis?
Yes, you have to mention the name, Dr. Sally.
Because
That's
even
why.
in front of the examiner, you didn't mention in front of me.
Yes, exactly.
Because I was afraid to say directly. Most probably, this is, I feel I deal hepatitis C like HIV. I feel difficult to give direct diagnosis in this point. So I keep my answer till the investigation. It will be most probably related to that blood transfusion.
But you don't have other differential, Dr. Sally. Right? And when I ask you, you mention it correctly. So mention it.
Dr. Basim, hemochromatosis is not mentioned. You didn't mention the 3.
Yes, of course.
No, I didn't mention hemochromatosis.
But she mentioned the porphyria tarda, which is the main complaint.
Yes.
related to the main complaint, with the rash. I mean,
Yes.
this is the main presentation or the main complaint diagnosis. Hemochromatosis, yes, supposed to mention because of bronze skin, but at least to say any diagnosis, she didn't mention any diagnosis. She said might be related, might be secondary, but she didn't
Yes.
mention any differential. That's why my question was
He's right,
direct.
he's right, Dr. Basim. She can, if she not sure for the patient, she don't want to give false information. She can tell like this, it is related. And I when I take this case, I mentioned like this, and I mentioned like this, but I mentioned in front of the examiner there is hemochromatosis, there is who is testing me. It is not a case of exam for me. It is a hemochromatosis. It is HCV related, viral related. Then he asked me what is the diagnosis. تمام. So in front of the patient can be if you are not sure, but in front of the examiner must be said to him clearly.
Yes. Dr. Muhammad, sorry, regard the hemochromatosis, is it idiopathic or I don't know the relation with the hepatitis C now and the hemochromatosis? Is it
It
related
is
to the blood
with
transfusion or what? Or idiopathic?
it is a syndrome with porphyria cutanea tarda. It is related to it. يعني if you read about it, I don't know the best way if it is related to skin damage or like this, but it is related to the syndrome itself. You have a HCV and this rash, then it will be there is hemochromatosis with the patient. So
The
it is not.
complication of hepatitis C, you mean?
I don't والله I don't have the information clearly.
It
But
is a very simple thing. Usually, porphyria cutanea tarda is due to iron overload. But my question is usually it is difficult to have a porphyria cutanea tarda and hepatitis C causing iron overload to the level of complications
Hemochromatosis.
like hemochromatosis. فالكيس هون عبارة عن center, it is like center, something very important. Porphyria cutanea tarda, it can be an association with hemochromatosis, okay, or it can be secondary to a liver disease, because porphyria cutanea tarda or AIP or porphyrias in general can be primary or can be secondary to chronic liver disease in some situations, especially if it is alcoholic or viral liver disease. In this case, usually in the exam, it will come as a two scenario. It's very difficult to be one scenario. Either
Yes.
you will have porphyria cutanea tarda plus hepatitis C
Hepatitis C.
or plus chronic liver disease with multiple risk factor. You will ask about, for example, blood-borne viruses risk factor positive, alcohol positive. So you will find multiple causes triggering chronic liver disease, and the chronic liver disease, one of the extrahepatic manifestation will be porphyria cutanea tarda. Or
this
the
patient,
second
Doctora,
scenario.
this patient is heavy alcohol. She didn't ask me. She's alcohol also.
Yes, that's why I'm telling you, usually the scenario come with multiple risk factor, so you will have multiple positive findings. And alcohol is very important whenever you deal with porphyria cutanea tarda. It should remind you with PAN. It should remind you with cryoglobulinemia. It should remind you with lichen planus. هدول الأربعة situations you must fulfill الليفر مع أنهم أبعد ما يكون عن الليفر. يعني you have to ask in these four situations about the liver, despite they are يعني when you will look at the PAN, cryo, LP, porphyric, you will forget, but you have to deal with it as if it is a jaundice case, not jaundice, let's say chronic liver disease case. Okay, so the first scenario will be a porphyria cutanea tarda with multiple risk factors related to chronic liver disease, and you will tell the patient most probably you have a secondary, not a primary cause for your skin condition. Second scenario is a rash, porphyria cutanea tarda, and it will lead you indirectly to hemochromatosis, because hemochromatosis is an iron overload condition, and porphyria cutanea tarda is the cutaneous manifestation of iron overload. Whenever there is iron overload and this iron deposit in the skin, it gives a photosensitivity and the porphyria cutanea tarda like skin eruption. And when you will do the biopsy and when you will investigate, or you will see the skin, the microscopic examination of the skin, you will find iron overload. But to have all the three and say
Yeah, it's difficult
that
to be an example.
porphyria cutanea tarda secondary to hepatitis C, and this is a condition of iron overload, to extend it reach a hemochromatosis level, this is a kind of, just like these cases are nice for practice. Let's say like a brainstorming thing, and to learn everything about porphyria cutanea tarda. So this is a teaching case to learn all the association of porphyria cutanea tarda. صح. There is a chronic liver disease association, there is a hemochromatosis association. I agree, but to say that this is a real case in the exam, because hemochromatosis by itself is a very big scenario. Hepatitis by itself have a lot of risk factors, and you have to inquire about what treatment, side effect of treatment, how he's following up, is he under control or not, social. You have to ask, and all the extra hepatic manifestation of hepatitis C. Okay, starting from skin, passing through mononeuritis multiplex, going like everywhere you have an extra nephrotic syndrome and renal side effect. So you have to cover extra hepatic manifestation of hepatitis C, plus the porphyria cutanea tarda itself, and skin history, which is usually also a big domain in your case. So try not to take this case as a real case, but to learn from it. All the association that Dr. Muhammad brought are real association with porphyria cutanea tarda, and you have to touch chronic liver disease in any case of porphyria cutanea tarda. But in such a combination, this will be very
Doctora,
difficult to be covered in
I
15
think
minutes.
if you notice during the case, Doctora didn't catch the case. But I think who put the case, he wanted to give some clue. Even for me, he put some clue for me.
For
When I
chronic
take the case,
liver
he didn't.
disease association with porphyria cutanea tarda.
When he gave me the case, he didn't me blood transfusion. He told me I have 2 months back. They told me I have some bug in my liver. So I thought that there is some viral with this skin manifestation. But if you notice during taking the history, she told me what about family history. I told her my father and one of family have diabetes also. So maybe
Actually,
the case here is the patient has familial hemochromatosis or hereditary hemochromatosis,
yeah,
and they put hepatitis C as a clue to tell her this is association with this.
porphyria cutanea. Yes, I actually I searched about it, Dr. Hint. There is overlapping with hereditary hemochromatosis. It can
between hereditary hemochromatosis and porphyria cutanea tarda.
exactly porphyria cutanea tarda.
في overlap لأنه الايرون
Exactly,
لك هو
yes, there is.
cutaneous manifestation of
Exactly.
iron overload.
Yes. So the iron will be overloaded from the hemochromatosis, can worsen the porphyria build-up.
Porphyria cutanea tarda, sometime
Exactly.
unmasked. Sometimes there is a porphyria cutanea tarda and get unmasked. Sometimes it is just like iron deposition in the skin secondary to uncontrolled hemochromatosis. But the case can be as difficult as hepatitis C virus acquired through repeated blood transfusion, and the blood transfusion has led to secondary hemochromatosis, and both hepatitis C and secondary hemochromatosis. لا بس حيكون في عندك انت underlying condition for the blood transfusion، يعني صار في عندك كمان لاعب ثالث بالقصة. There is third player, the indication of the recurrent blood transfusion. I think such a scenario is just like teaching.
Yeah, it's very rare scenario. Yes,
Yes,
you're right.
to collect all the causes together and to teach us one thing: don't overlook the HIV risk, not HIV, blood-borne viruses risk factor. Well, blood transfusion is one of them. As soon as you find hepatitis C virus، بغض النظر عن وجود الكيس على أرض الواقع أو عدم وجوده، لا يحق لأي شخص، it's never allowed to see that you have a case with hepatitis C and you did not explore the blood-borne viruses risk factor, all the 6 بما فيهم الترافل والكونتاكت والسكشوال والبيرسينج والتاتوينج والبلاد ترانسفيوجن والدنتال بروسيجر والنيدل شيرنج اند بارتي دراجز. ف it is a big، يعني اي حدا حيحاجك، يعني حيحاجج اللي عمل الكيس whatever
the
diagnosis, but
yeah.
you did not ask about those risk factors. How come? And you have a patient with hepatitis C virus. So this is the point. if we want to learn something, we have to learn the association between some cutaneous diseases and chronic liver, and we have to learn that whenever we have a hepatitis case, we have to fulfill the bloodborne viruses risk factor. Two
Yes,
teaching points, you should never give up on them.
yes. Thank you, Dr. Hind. I will comment only on the performance of Dr. Sally. Again, the same slow question, or the rate of the question is slow a little bit. So try to speed up your question rate and the flow of questions. Why? Because you have a lot of things to cover. In this scenario, as Dr. Hind mentioned, you have to cover the risk of or the risky habit, how this patient is getting the infection or getting the infection, plus the alcohol history you missed totally, and also here the question of recreational and sharing needs. The same question for risk habit. I mean, the same also it affects your examination. You didn't finish your examination appropriately because of the long time history taking. So again, the practice is the solution. You have to practice what to ask, what not to ask. Okay, there is some question no need to ask, and there is also one comment. Sorry, silly comment, but it's very really affecting your time. You have to be sorry only during taking the complaint. I am so sorry for your complaint once only. That's enough to show the sympathy and empathy. Otherwise, if you repeat them, I am so sorry for your complaint, it wastes a lot of time. Yes, it's a second matter of second, right? But if you repeat it many times, it will be like 1 minute. I'm so sorry for your complaint again. Once you hear the history and the complaint, I start this complaint since 2 days and I'm suffering a lot. I'm so sorry for your suffering. I'm so sorry about your suffering. That's enough, very enough to say it once. If he said it again during the impact on his daily activity or the impact on his job, you can be sorry again. But not every symptom he has, you have to be sorry for it. Okay. For example, if you are taking the systemic review question, I have chest pain. Don't say I'm so sorry for your chest pain. No, halas, enough. What you ask, what you said earlier, that's enough. Tell me about your chest pain. I have chest pain scale of or the description, the scale, the other question. But no need to be sorry every now and then. Okay. Otherwise, yeah, the case is difficult. Really, it's a teaching one. You catch it. Sorry, you didn't catch it, but you learn it. Today you learn the case, the complication of hepatitis, the association, the hemochromatosis, the complication of hemochromatosis, the thyroid affection. It might be in the hypothalamus, it might be in the pancreas, as you know, the hemochromatosis complication. So you can screen them whenever you have hemochromatosis case. Apart from that, hemochromatosis usually comes as hemochromatosis. I mean the hereditary type. You can catch the case easily, and you can do the screening of other organs affection, started from the hypothalamus, as I said, end by the testicular failure and other pancreatic manifestation and so on, and the skin, of course. Okay, the heart, don't forget also, and the skin, as I mentioned. This is my comment to you, Dr. Sally. If you have any question, please, you can raise.
No, it is clear. Thank you.
Yeah.
Regarding the last comment of Dr. I think Hind, which was commenting since a while,
Okay.
she mentioned HCV. Really, when come to you, you will come to your mind cutaneous complication like what we give today, percutaneous cutaneous tarda, perfect cutaneous tarda, and
Lichen planus.
cryoglobulinemia. Like imbalance, I think rare to come along كده, but يعني cryoglobulinemia can become
Yeah,
before
cryoglobulinemia and PAN,
and
polyarteritis
yes,
nodosa.
yes.
Yeah.
But I need to
Polyarteritis with hepatitis B.
yes بروتاس وهيباتيتس بي yes but خلاص once
But
risky behavior
no,
you
don't take it for granted, hepatitis B.
Mhm.
Unfortunately, in the exam, the surrogate, sometimes he don't differentiate whether you have B or C.
Yeah, but I
Whenever
mean,
there is,
logic-wise,
yes,
scientifically.
whenever there is a viral infection, يعني
Yeah.
for us practical exam-wise, PAN and the cryo should be excluded until proven otherwise.
Yes.
Irrespective, this was for MCQ and theoretical knowledge, B, PAN, C, cryo. But for practical point of view, hepatitis, chronic hepatitis, exclude both.
You
Okay.
can't differentiate by history which one. Whatever you have high risk blood-borne virus, خلاص you will put in your mind as a basis exam hepatitis B and C
Hepatitis,
and
yes.
HIV. My question here, how to differentiate? I know طبعا the answer. I am asking Dr. Sally if she can answer. She was me with the case. By one question, how can you differentiate? It is cryoglobulinemia or cutaneous tart?
I think cryoglobulinemia related to coagulopathy related problem like
No, I need now we are in history taking. You are asking me one question. You can differentiate. You can take one way of this. يعني he will never give you both cases because both cases يعني different management and different investigation. He will not give you both to يعني no time for both cases. But
sun
you see,
exposed. The sun exposed related for porphyria.
yes.
Appreciate.
The other question for cryoglobulinemia.
الopposite. الsun شو بتعطينا heat. في asked about what
الcold
عليك يا نور. الcold usually cryo. I hope this is your question, Dr. محمد.
Not only cold, Dr. Ayanda. يعني you will tell him يعني if I answered you at this time, if I answered you this time in my arms or on my back or on my hip, I have another rash. One thing you will tell him if you press on it, if it is blanchable or not, or you by yourself you press it. تمام. Once خلاص you are away from the skin sun exposed area, خلاص you will put in your mind vasculitic rash. If vasculitic rash, if it will be not blanchable and it will be elevated, it will be above the skin.
والporphyria cutanea the nature of the rash is fluid filled vesicles usually. فيعني we can say إنه easy to differentiate لأنه the porphyria cutanea is usually vesicular rash.
Yeah.
It is yes يعني classified as vesicular, while cryoglobulinemia is a
Vasculitic rash.
vasculitic rash.
Yeah.
Plus إنه if the patient طب okay let's say إنه the patient his rash has resolved. And so I will ask him, how did this rash progress? He described. If he couldn't describe, the photosensitivity with distribution will help to differentiate.
Mhm.
يعني at least you have now 3 lines of defense. First defense line, you will see the rash. If the rash has resolved, how did the rash progress? If the patient couldn't explain himself, then you can ask some characteristic features like the photosensitivity, being worse with cold, because usually cryoglobulinemia is also associated with Raynaud's. And the third question, the distribution. Is it sun exposure or the sun exposure areas ولا hidden body areas اللي هي it has nothing to be related to the sun يعني like the back or the extremities or dependent area. A nice way of differentiating since it is a case with positive hepatitis C virus.
Okay, thank you, Dr. Muhammad, for this question, and Dr. Hind, as usual, for the comment. Anyone has a question? Do you want to ask any question, Dr. Sally, regarding this case?
No, it is fine. Thank you.
Oh, thank you too. Any question, Dr. Muhammad?
Thank you, Dr.
Anyone?
Khalid.
Okay,
Thank you.
so anyone has question? Any comment? Dr. Khalid, when I ask about rash, it's better if we ask any skin changes, not as a relevant system. Skin rash or musculoskeletal system or skin or rheumatological system. Whenever you have skin rash, better to ask any skin rash elsewhere, not only in the hand. That's why I think this regarding the bronze skin in the neck. Whenever you see skin rash, Dr. Sally, show me any other change in the skin, or if you have any skin change, either hypo or hypopigmentation, or increase or decrease of the color of your skin, okay, in this way. Plus the other question for joint stiffness, as if you want to roll out systemic lupus and other rheumatological condition. By the way,
Sometimes
this
Dr. Bassem, as this case, he not noticed that. And he can tell you, but he will tell you, no, I don't. I
yeah,
don't
yeah,
know.
yeah. It's okay. You can discover in the examination.
Yes,
I will
and the
ask you
examiner sometimes tell the surrogate, don't tell him, make him go.
exactly. Yeah, to specifically ask about this bronze skin or any change in the skin. Okay, if I want Dr. Sally, I want you to answer this question. What is very similar to this rash in the same area of the hand? Dr. Sally.
Yes, I hear you.
Yeah, something very similar, and it's also sun exposed rash, red knuckles over the knuckles of the hand.
SLA related rash? Or?
It's not CCLE, something related to CCLE.
She did it, Dr. Basim. She included, but she forgot.
Yeah, Guttrum papule. Thank you, Dr. Riham. Yes, it's Guttrum papule. The same, almost the same appearance. Red over the knuckle of the hand. Dermatomyositis related. Guttrum papule. Okay. Yeah, you have to look at it. See it once because it comes as dermatomyositis association. You can even put it as a differential. Skin related, skin rash, red, and in the same area, and also it's sun exposed one,
Must
photosensitive
be,
rash.
Dr. Basim, sorry for interrupting you.
Yes,
For the
yes.
case, it goes very strictly to tell like this. I need to rule out all other
Yes,
photosensitive rashes. I asked
exactly.
about hair loss, no SLE. I asked about any pain muscle or difficult to coming, no dermatomyositis.
Yes, 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 you're right.
It should be mentioned, يعني not
Yes,
percutaneous. This is your diagnosis, but the differential other photosensitive must be mentioned in front of the exam.
exactly. It's very important to rule out SLE from the start. SLE not only as a rash in the hand, even in the face. Any rash in other area in your face or your body. Is it related to the sun? It's very important. Even you can put here SLE one of the differential, and it's very good differential and correct one. Okay.
Yes, okay.
Yeah. Thank you, Dr. Sally. Thank you, Dr. Rihan Mansour, Dr. Papule, Dr. Huda as well, dermatomyositis. Yes, this is the answer.
Yeah.
Yeah, did we answer your question, Dr. Khalid? Any other question from others? Anyone want to add any comment? Clear all? Yeah, okay. Thank you, Dr. Khalid. Thank you, Dr. Muhammad and Dr. Sally. Thank you, Dr. Hind, for your comment, and others as well. Dr. Ahad and everyone attended today. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.